urinary system. Before we start, I just want to remind you that blood volume and blood pressure are directly related, because we're going to talk about how the urinary system can change the blood volume, which will then change the blood pressure. So this is the urinary system, consisting of the kidneys, the ureters, the bladder, and its functions include adjusting blood volume and blood pressure, regulating plasma concentrations of sodium, potassium, chloride, and other ions, stabilizing blood pH, removing drugs, toxins, and wastes from the blood. So this is where the urinary system is located in the body. Looking at a cross section, you can see the kidneys are in the very back of the abdominal cavity. Here is an actual kidney, and here's a diagram of the kidney. And inside these renal pyramids is where the urine is actually formed, and then it will drain into these papilla and then finally into the ureter, which will take it down to the bladder. And so here's a close-up on that pyramid, and we can see some cortical nephrons, which are mainly in the cortex, and some juxtamedullary nephrons, which are found more in the medulla of the kidney. This is a better picture of a nephron, and nephrons are the functional units of the kidney. They're made up of the renal corpuscle, which consists of the glomerulus and the glomerular capsule, and this part functions in filtration. That's what this green arrow means. Water and the things dissolved in it leave the blood and become filtrate. Then in the proximal convoluted tubule, we reabsorb nutrients and water. Then in this nephron loop, or it's sometimes called the loop of Henle, this establishes an osmotic gradient in the renal medulla, and this allows us to concentrate our urine if we need to. In the distal convoluted tubule, we have secretion and absorption going on, reabsorbing nutrients and getting rid of wastes. And then in the collecting duct, it's mainly water reabsorption, depending on the body's needs. So this shows the blood supply to the kidneys, comes in from the renal artery, and then it branches into all these smaller arteries until you get to the afferent arterioles, which actually lead to the glomerulus, then to the efferent arterioles, and then it goes through this series of veins back to the renal vein. And if we look at blood flow through the glomerulus, this is where filtration happens, so a lot of things leave the blood in the glomerulus, and then in the peritubular capillaries, a lot of that stuff is reabsorbed back into the blood vessels. This shows a juxtamedullary nephron, which has a much bigger loop of Henle, much longer, and it has what's called the vasa recta around its loop of Henle, and it helps to establish the osmotic gradient in the renal medulla. So the goal of urine production is to maintain homeostasis by regulating the volume and composition of blood. Three organic wastes that are excreted are urea, creatinine, and uric acid. And the three processes that occur: first one is filtration. Blood pressure forces water and solutes across the membranes of the glomerular capillaries and into the capsular space. Then we have reabsorption, where water and solutes are removed from the tubular fluid into the blood, so we reabsorb the good things. And then secretion, we secrete solutes from the blood into the tubular fluid, so things that are bad or things that we have too much of, we can secrete them from the blood into the filtrate, and then we'll get rid of it. we're going to look at the functions again of the various regions of the nephron. The glomerulus, its function is filtration. Then in the proximal convoluted tubule, we have the absorption of most water, all organic solutes such as glucose and amino acids. Then in the nephron loop, in the descending limb, we reabsorb water, and in the ascending limb, we reabsorb sodium and chloride. And then in the distal convoluted tubule, we absorb sodium and chloride and sometimes calcium and water. Also there we have secretion of hydrogen ions, ammonium, creatinine, drugs, and toxins. And then the collecting system or collecting duct. There we have reabsorption of sodium, bicarbonate, and water if needed. Also secretion of potassium and hydrogen ions if needed. With the functions, the peritubular capillaries will be found around the tubules, around the proximal and distal convoluted tubules. And their job is to return reabsorbed water and solutes to the general circulation so that things are reabsorbed from the tubules into the blood. And then the vasa recta are the blood vessels around the nephron loop that help set up the osmotic gradient in the renal medulla. So this is a close-up on the glomerulus, and we can see the filtration membrane. Here's an actual picture of one. It's made up of these fenestrated glomerular capillaries. It's hard to see, but these capillaries have holes in them. So you can see that here, holes in the capillaries. And then these podocytes are these cells from the glomerulus, and they form what are called filtration slits. And here's a closer up view on an actual filtration slit, and so that's how things are filtered through. They go through these holes in the capillary and through the filtration slits, and this makes it so only small things can get through. Blood cells and large proteins can't get through there. Also on this picture we can see the mesangial cells right here, which are close to the glomerulus. These can contract or relax to control the capillary diameter, and that's going to be important. So this is found right in here where the blood's coming in. This is going to be important in controlling the pressure, which is going to determine the amount of filtration that's happening. So next we're going to look at the factors controlling glomerular filtration. First we have the glomerular hydrostatic pressure, which is just due to the blood pressure, and that's pushing things out. That's right here. Then we have the blood colloid osmotic pressure. It's due to proteins in the blood, and it's pulling things in. Then we have the capsular hydrostatic pressure, which is due to the fluid in the glomerular capsule. It's also pushing things in, but we can see the net filtration pressure is out. The glomerular filtration rate, or GFR for short, is the amount of filtrate produced each minute. And the kidneys maintain a normal GFR by autoregulation and central regulation. So if the GFR falls, autoregulation can increase glomerular blood pressure by dilating afferent arterioles, as we see right here, contracting mesangial cells, or constricting efferent arterioles. All those are going to increase the pressure in the glomerulus and make more filtering happen. So that's autoregulation. If that's not enough, then we have some other regulation mechanisms. Central regulation involves both neural and endocrine mechanisms. The juxtaglomerular complex, or JGR for short, it produces renin. Renin's a hormone which causes the formation of angiotensin 1, which is then activated to angiotensin 2. Angiotensin II has several mechanisms of action. It's going to constrict the efferent arterioles, which will increase the glomerular pressure. It will also trigger aldosterone secretion. This is going to increase the sodium reabsorption. It also stimulates thirst centers. That's going to increase the amount you drink. It also increases ADH production. And it will increase the sympathetic tone. This is going to increase the cardiac output and cause vasoconstriction. So all of those things are going to increase the blood pressure. Now each kidney, there's a mistake in your handout here. It should say each kidney has about 1 million nephrons, giving them 64 square feet of filtration surface, which is huge if you think about that's contained in your tiny little kidney. The average glomerular filtration rate is about 125 milliliters per minute, and each day the blood is filtered about 400 times. 99% of that filtrate is reabsorbed right back into the blood, but the bad stuff is not reabsorbed. So let's look at what happens in each segment of these kidney tubules. This is the proximal convoluted tubule, or PCT. In this, glucose and organic nutrients are actively reabsorbed. Ions diffuse back into the blood, and water follows by osmosis. So all the nutrients and good things are reabsorbed right back into the blood. And this shows what's going on in the distal convoluted tubule, or DCT. We can see sodium and potassium are being exchanged. Hydrogen ions then can be exchanged for sodium. And toxins and drugs will be secreted here from the blood out into the fluid to be get rid of. The nephron loop is called the countercurrent multiplier because fluid is moving in opposite directions in adjacent tubes. The descending limb right here is permeable to water, but impermeable to solutes. So as water leaves, the filtrate becomes more concentrated. So this shows, here's the descending limb, and water is leaving and the filtrate is becoming more concentrated. And then in the ascending limb, it's impermeable to water, but ions are actively transported out, so the concentration in the filtrate decreases. And this is showing again, so in the loop of Henle it is concentrated, but then as it moves through the ascending limb it becomes less concentrated, and then depending on the needs in the distal convoluted tubule and the collecting duct, they have variable permeability to water depending on basically how much water you're drinking. So if you're drinking a lot of water, you won't reabsorb water and your urine will be clear. If you're not drinking enough water, you'll reabsorb most of the water and you'll have very concentrated urine. Urine volume and concentration are hormonally regulated. 85% of the water that is filtered is reabsorbed by osmosis, and this is called our obligatory water reabsorption, so that's going to happen no matter what. The remaining 15% can be reabsorbed by what's called facultative water reabsorption, so that would happen in the distal convoluted tubule and the collecting duct. Antidiuretic hormone is the hormone that makes us reabsorb water, and if we're drinking plenty of water, we won't make that. And so if no ADH is present, water is not reabsorbed, we produce large volumes of dilute urine. And if ADH is released, it causes the appearance of water channels called aquaporins in the distal convoluted tubule and the collecting duct. And water is reabsorbed as it flows down through the medulla. So lots of water reabsorbed and will produce a small volume of concentrated urine. The filtrate produced at the renal corpuscle has the same osmotic concentration as the plasma, about 300 milliosmoles per liter. See, that's what it is in the blood, and that's what it is right here at first. This osmolarity does not change in the proximal convoluted tubule because water and ions are reabsorbed at the same rate. In the descending limb of the nephron loop, water moves from the filtrate to the blood by osmosis, increasing the osmolarity. So you see it's becoming more concentrated. Osmolarity is another way of measuring concentration. In the ascending limb of the nephron loop, sodium and chloride are transported out of the filtrate, and this lowers the osmolarity. So here we are coming up here. Osmolarity is getting lower. Then in the distal convoluted tubule and collecting duct, reabsorption of water and ions is hormonally regulated. Water and ions that are reabsorbed are carried away by the vasa recta here, and that maintains the osmotic gradient in the medulla. Renal failure occurs when the kidneys are unable to perform the excretory functions needed to maintain homeostasis. Chronic renal failure is a gradual deterioration of kidney function. Acute renal failure is sudden and can be caused by drugs, lack of oxygen, or trauma to the kidneys. The only treatment is dialysis or kidney transplant. In dialysis, the patient's blood is run through a selectively permeable membrane in a dialysis chamber. So like we see here, wastes will move from the blood to the dialysis fluid, and protein and nutrients will stay in the blood. So they set up the dialysis fluid so that it will have the right amount of ions that our blood needs, so that way if the blood is high or low in a certain ion, if it's high in a certain ion, those ions will diffuse into the dialysis fluid. If the blood is low in a certain ion, that ion can flow from the dialysis fluid into the blood. But mostly it's wastes that are leaving the blood. And here is someone actually undergoing dialysis. They hook up tubes to one to an artery and one to a vein in your arm. And so it pulls the blood from the artery and moves it through this dialysis chamber where it goes through that dialysis fluid, and the wastes move out of the blood, and then it's returned to the body nice and clean. This is a picture showing how we get rid of urine. So it's formed in the kidneys, and then ureters, and there's another mistake on your handout. It should say ureters carry urine from the kidneys to the urinary bladder. So here's the kidney, here's the ureters going down to the urinary bladder. Depending on if you're male or female, the location is a little bit different, but it's basically the same. And here's a close-up on your bladder. The bladder is a temporary storage reservoir. It can hold about 1 liter of urine. Urination involves a reflex coordinated by the nervous system. This is called the micturition reflex. It's activated by stretch receptors in the bladder. This will send a signal to the brain, and then that's going to stimulate the detrusor muscle to contract. The external urethral sphincter is skeletal muscle, so that has to be voluntarily relaxed. Then we're going to talk about some disorders. Pain in the superior pubic region, so up in here may be associated with urinary disorders. Pain in the lumbar region may be caused by kidney infections or kidney stones, because that's where the kidneys are located. And irritation of the lining of the ureters or bladder can lead to an increased urgency or increased frequency of urination. Polyuria is the production of excess urine. This usually results from hormonal or metabolic problems like diabetes. Oliguria and anuria are insufficient urine production and are signs of serious kidney problems. Incontinence is the inability to voluntarily control urination, and that's no fun. In urinary retention, normal urination does not occur. This is commonly caused by enlargement of the prostate in males. And renal disorders often lead to protein loss in the urine and generalized edema or swelling.